All right, Tyler, this first one's for you. So this is a 70-year-old male after years of long-standing left low back pain. Now he comes back with 3 months of worsening pain and groin numbness, several weeks of urinary incontinence, several days of fecal incontinence as well. This exam, I highlighted the relevant findings here. He has decreased perineal sensation, but otherwise is fully intact. So what would your next steps be in terms of what you want to do?
I want to get like an MRI of like lumbar spine.
Okay. So they actually got a CT right before they, called you. They got a CT of the lumbar spine, and down here, at the bottom, this is what they found. So can you kind of describe what's going on right here in the CT?
Sure. So it looks like some lytic lesions. Oh, yeah, okay, yeah. It looks like there's like a lytic lesion in the like sacrum, like eroding some of the bone. So there's some hypodense lesions.
Yeah, exactly. Yeah. So this is a CT of the sacrum, and you can what are these two large bones on either side?
The iliac crest, or like
Yeah,
iliac.
exactly. Right. So it's like part of the pelvis. So you can see there's this like big lytic lesion kind of on both sides, involving the sacrum and the iliac crest, and you can see these holes here are the neural foramen, and that's one of the nerve roots, and you can tell it's kind of going into everything here. So this is your MRI that you ordered of the lumbar spine. So what sequence is this, and what do you see?
So it's T2. And you can see redemonstrated here, like in the, yeah, exactly, the S1 2. There's like in the kind of in the whole sacrum eroding it, there's a large lesion. And do we get contrast?
Yeah, so this is the contrasted MRI.
Okay, so it's contrast, like homogeneously contrast enhancing, suspicious for like I mean chordoma, potentially, like I guess a metastasis is a possibility. It's a contrast enhancing lesion in this area.
Good. So this is another one other cut as well. So yeah, exactly. You said two things. One was chordoma in this region. One was metastasis. What are some other things you can think of?
Like at the phylum, you can get like the, I mean, it's a little, I guess we're a little below that level kind of, but like a mix of papillary ependymomas, right? There's maybe a hemangioblastoma. I don't know. I know it's not like necessarily the right imaging characteristics or location.
Sure. So yeah, this lesion kind of involves more of the bone as opposed to the directly arising from the neural elements. So there are a couple of things. Chordoma, there's chondrosarcoma. It's very similar both radiologically and histologically. Giant cell tumor, plasmacytoma, metastatic disease. What kind of cancers can you think of that metastasize to the bone preferentially?
Yeah, like prostate cancer, breast cancer, a lot, sometimes lung.
Yeah, exactly. Prostate, breast, thyroid, lung, colon cancer, like all things to consider in this area. So I'll turn it over to Dr. Saad for the pathology.
Okay, thank you. All right. Okay. Okay, so this is the tumor, and here you have two different growth patterns next to each other. At low magnification here, you can appreciate the presence of what we call myxoid or chondroid stroma and some cells, which I'll show you in high magnification a little bit. And this is the tumor, which is the second component. It's completely different. It appears to be fully differentiated, meaning if you look at the tumor cells, they don't display their identity. And these two components are separated by this thick fibrous band. So let's concentrate on the first component. This is a straightforward chordoma, meaning again chordoid or myxoid background, and all these cells with large vacuolated cytoplasm, we call them physalliferous cells, which is a buzzword for chordoma. And this is another feature where you can see clearly the physalliferous cells. The second component, again, it's dedifferentiated. You look at the tumor cells, they show significant atypia and pleomorphism, significant variation in size and shape, prominent nucleoli. Now back to the tumor, brachyury, which is a transcription factor involved in the notochord development. So you would expect brachyury to be positive in a chordoma, and it is positive in the chordoma component, while the dedifferentiated component is negative. So this is a dedifferentiated chordoma, grade 3 out of 3.
Thanks, Dr. Saad.
Sure.
So yep, as Dr. Saad mentioned, this is a dedifferentiated sacral chordoma. So I guess, Sumedh, what would your approach to be to treat this? Does this need treatment? How would you treat this?
Hey, yeah. So unfortunately, sacral chordomas, I would say yes. Unfortunately, this patient needs en bloc resection, given the fact that it's such an aggressive tumor. The option for this would be a total sacrectomy, which would entail essentially removing the sacrum in a staged fashion. Essentially, like we would have to go from like the utilization of multiple OR teams, general surgery for approach. I've seen one of these done a few places, and what generally tends to happen is a myocutaneous flap, pedicalized myocutaneous flap from the front, which would be plastics, removal, essentially a mobilization of the abdominal musculature, abdominal contents to the side with general surgery, plus or minus resection of any bowel that would be in the way, and then into anterior approach to try to remove the anterior portion of the sacrum, and then flip over on the next approach, and then remove the sacrum from behind, and then fixation with iliac screws, and then fixation to the actual spine itself, because the patient will not have a sacrum. So you need to essentially recreate a sacrum using instrumentation, and then that pedicalized muscle flap from inside gets put in the back. So that's kind of the approach for something like this. Unfortunately, big surgery, but he needed, if they ultimately elect for treatment, then it would have to be a big sacrectomy, big surgery, multiple teams.
Okay, yeah, that's great. Like you mentioned, I think the anterior versus or posterior versus anterior posterior kind of approach depends more on the size of the tumor, but especially for something this size, he would need a staged approach, multiple both anterior and posterior, and like you said, it has to be kind of sort of reconstructed. So this is what was done here. All of these reconstructions are very complex. You can see this is the one from the OR, but you can see them in the literature as well. It's you essentially, like you said, have to reconstruct the lumbosacral junction, and that's what's done here. So it's a little bit about sacral chordoma. Like Dr. Saad said, it rises from notochord remnant. It's malignant, it's relatively slow growing, and very locally aggressive. Out of all primary bone tumors, it accounts for about 1 to 4%. Can within the spine, can also obviously occur in the clivus, as you guys know. Sacral, it's relatively rare in the overall epidemiology, but it's actually the most common primary malignant tumor in the sacrum. And because it's so slow growing, the neural elements often have time to adapt, and so you actually get involvement within the neurovascular structures before symptoms arise. You can see here, this is the kind of frequency of presenting symptoms, and the most common one is lower back pain. It's still blurry, but the other ones say sciatica, urinary tract infection, but the most common symptom is low back pain with presentation. Just very quickly about kind of the developmental aspect of this. So we have the somites and the neural crest, and then the notochord, and ultimately the notochord will give rise to the anterior part of the vertebral body, the nucleus pulposus. And so a little bit about the genetics of sacral chordomas. Both sporadic and hereditary chordomas have been linked to the T gene, which is located on chromosome 6. And this actually encodes for a transcription factor that's involved in the development of the notochord. So the difference between sporadic and familial chordomas. So sporadic chordomas have a single nucleotide polymorphism within the T gene, whereas familial chordomas have been associated with like actual duplication of the T gene. If you look at the epidemiology, actually S1 is the least common level that's involved. Most commonly it involves S2 and S3. It's predominantly in Caucasian males, more in males than females, typically seen between the 50s and the 60s. A relatively small number of patients present in their 30s and 40s. So the tumor actually arises from, the notochord remnants of the sacrum. It can grow very large because it's so slow growing. And it really involves almost everything. You can involve the muscles around the hip, the SI joints, as it was seen here, but you typically don't see anterior invasion because the presacral fascia is relatively thick. And so when you go look at anteriorly, most of the time the rectum is spared and the retroperitoneal structures are spared. Sacral chordoma can metastasize most often to the lung, bone, liver, lymph nodes, soft tissue, and skin. As Dr. Saad mentioned, pathology, pathognomonic, if you hear phyliciferous cells, it's pathognomonic and brachyury. And so if you look at dedifferentiated, so there are different types of chordoma, dedifferentiated chordoma, Conrad chordoma, which is based on the kind of the histological differentiation seen here. And as I mentioned, there are a couple other things that are similar to chordoma histologically, or sorry, on imaging. And so you can differentiate it from these other pathologies, based on staining for EMA and pancytokeratin. So as Sumedh said, first line of treatment is unblocked resection, but you of course want to try to preserve as much neural function as possible. It's not really amenable to primary treatment with chemoradiation, but this can be used to supplement it after surgery. There have been studies looking at imatinib for treatment of chordoma after resection, if unblocked resection is not necessarily possible, which has been shown to be good for progression-free survival. The larger the tumor, the worse the prognosis is. And Sumedh, as you mentioned, you have to usually do a complex spinal pelvic reconstruction. And so recurrence is possible even with what is presumed to be on-block resection, because the tumor actually has several satellite lesions and a pseudocapsule around it. So unless you have really, really wide margins, you can't necessarily, even though you may take out everything that you see, it's kind of hard to get full disease-free surgical resection. But again, because it grows involve the foramen and the vascular structures, is often very difficult. All right, it's the second case. Let me see who's here.
Hey, Vignesh, this is Evan. Just real
Yeah.
quick, I don't know, did you ever, when you're looking up this stuff for this case, did you ever find anything regarding malignant degeneration of chordomas into other types of tumors after treatment, like after these patients get radiation?
I did not, but I can take a look. I can send out an article.
No, it's just interesting. We had a chordoma with Dr. Morkos, one of his patients, and they had a malignant degeneration after recurrence, after proton beam, and and it turned out to be a rhabdomyosarcoma on the second pathology. So I just didn't know if there was any evidence for stuff like that in the sacrum, but
I see. I'll take a look. I can send it out to everyone.
All right.
With any articles I find.
Yeah, sounds good. Thanks, man.
Yeah, of course. The next case, Adam, are you on?
Yes.
Perfect. So this is a 56-year-old lady with 1 year of symptoms of dysesthesias in her fingers, mostly in the second and third fingers of both hands. They got worse. She had some pain in her left wrist, shooting pain into the fingers of both hands, worse in the middle fingers on the right. She has some intermittent left shoulder, left scapular pain. She also feels like her right hand kind of spasms and claws. On exam, she's fully, based on everything that we could see in the preoperative visit, she was fully intact. What do you want to do?
I want to do a Tino and Fallon exam as well. Any concern of carpal tunnel on her?
No concern for carpal tunnel.
Okay. So we can start then with the imaging for the cervical spine. So start with the X-ray initially, and then get a CT.
Perfect. So well, they got they got a CT, and then they couldn't really tell anything, so they got an MRI scan. What do you see here?
So you see this intradural intramedullary lesion that extends from C6 up to T1. So on the differentials, you can see the cystic component. So highly on the differentials for this patient would be the ependymoma most likely, and the astrocytomas and hemangioblastomas in that order.
Okay, good. Do you want a contrasted study, or
Yes.
what would you expect to see if it was on the contrasted study if this was an ependymoma?
So you can see the contrast enhancement of the that it will be contrast enhancing in the periphery, but it would be like a cystic component mainly.
Okay, good. And then so what component is this tumor in? So you have like intramedullary tumors, intradural extramedullary tumors, and then extradural tumors. What component? All those things you mentioned, what component of the spine are they in?
So that would be like intramedullary. This is an intramedullary component.
So this is the contrast enhancement, like you said, not really any significant contrast enhancement because it's all cyst. So what is this thing here? If you go back to this, like what do you think this thing is? So this is the GRE sequence. So there's this like black dot. What do you think that represents?
I'm not quite sure what this is.
So on GRE, yeah, I mean anything. So GRE is a good sequence to look for blood. So this was probably hemosiderin that accumulated. Kind of you can see here at the sort of the top and the bottom in that area.
Got it.
So yeah, you mentioned your differential diagnosis for this. So intramedullary intradural tumors, ependymoma, astrocytoma, hemangioblastoma. You can have some rare metastases. And then so Dr. Saad for the pathology.
Okay, thank you. Okay, so this is the tumor at low magnification. Here you can see a little bit of the ependymal lining, which kind of always cute to see. And this is the tumor that is involving the subependymal zone. Higher magnification, this is a very good example of what we call ependymal pseudo-rosette. So what is ependymal pseudo-rosette? Is a rosette where the center of it consists of a blood vessel. That's why it's called pseudo-rosette. But more importantly, it is ependymal because here you can see very nicely the processes that are coming out of the outer aspect of the vessel into the cytoplasm of the ependymal cells. You rarely see that, but we got lucky in this particular case. And one of the features of ependymal pseudo-rosette is that the processes that I just showed you are positive for GFAP, while the tumor cells in ependymomas, they're at best focally positive. So here you can see a significant number of cells are negative, while the processes in between, especially around the blood vessel, are positive. Another characteristic feature of ependymal differentiation is the dot-like positivity of EMA, epithelial membrane and antigen. Ki-67, which we always do, is about 1 to 2%. So this is an ependymoma grade 2.
All right. So let me see. Victor, how would you treat this?
So there's an obvious lesion that is isolated. It's a surgical target. So you would go for a surgical resection for both diagnostic purposes and also symptomatic purposes as well, aiming for a gross total resection.
Okay, good. So these are kind of the steps, of that. So you want to do a midline incision, to do a laminectomy above and below the tumor. You can do an ultrasound before you open dura to make sure you're above and below kind of the poles of the cyst. Open the door at midline, find the dorsal columns. This can sometimes be difficult because, you know, the spinal cord may be rolled, and so it may not be necessarily at midline, but you want to open, you know, right at midline. Identify the borders of the tumor, kind of like separate, and sometimes you can go up and below to identify the top and bottom pole, and then the sides. This is probably going to be too difficult to, you know, too large to just pull out, so you can internally debulk it and then kind of roll it in on itself, which is what was done in the OR here. And then you want to obviously monitor motors. You want to have neuromonitoring for this case. So just a little bit about ependymomas. You can, you know, they obviously occur in both the spine and the brain. The spinal ependymomas account for 75% of total ependymomas. They arise from the central canal, and cranial ependymomas are from the ependymal cells of the ventricles. As seen here, frequently associated with cysts. These are typically benign. And ependymomas account for about 60% of all spinal cord gliomas. The other ones, of course, like I mentioned, are astrocytomas and spinal GBM. There's a slight predominance in males when it comes to these, typically seen younger, age 30 to 40. Ependymomas are pretty slow growing, and so, you know, again, they can present with symptoms after the tumor has gotten much larger. The majority of them occur in adults, and, you know, a smaller amount less, you know, in children. About 50%, you know, it's kind of divided in terms of spinal ependymomas. About half are in the cervical and thoracic spine, and then half are in the conus, which are, of course, called myxopapillary ependymomas. The grading is based on degree of malignancy seen on, you know, histology. So myxopapillary ependymomas and subependymomas are grade 1. Anaplastic ependymomas are grade 3, and you can see here.
Dr. Kumar, just quick correction. Myxopapillary ependymoma is not grade 1 anymore.
Oh, it's okay.
Yeah,
grade
so
2.
it's a grade 2. So the only grade 1 is subependymoma.
I see. Okay, cool. Thank you. In terms of the genetics, typically associated with loss of chromosome 22q, but myxopapillary ependymomas are also associated with mutations in chromosome 7. The MDM gene, which is involved in P53 mediated cell growth, is often found to be overexpressed, and with increased grade of ependymomas, you also have higher Ki67. So treatment, as Victor said, you want to try gross total resection to the extent that you can avoid any neurological deficits. So you don't, you know, when you treat the tumor, it'll, you know, eventually lead to resolution of the cyst. And if gross total resection isn't necessarily possible because of the location, you could do, you know, radiotherapy for whatever is left. This consists of external fractionated beam radiation with a cumulative dose of 54 gray. And if you have disseminated or metastatic disease, which can be common with drop meds, you would need to undergo craniospinal radiation. Let me see who's here. Long, are you here?
Hi, Vignesh. Yeah, I'm here.
Okay, great. So this is a 64-year-old male that had sort of a complex sort of history leading up to this. He had a complete thyroidectomy 1 year ago. It was found to have a Bethesda grade 3 thyroid nodule, which means it's suggestive of cancer risk. And then 3 months ago, he had this right forearm lesion, was found to have melanoma. And then he got a PET scan as part of the cancer staging and showed this thoracic tumor and also lymphadenopathy in the mediastinum, and as well as some of the right hilar lymph nodes. He had 2 biopsies at some other hospitals in Florida, and then came here, you know, kind of for a different opinion. His only symptom is really mild dizziness when he leans to pick up items, but he doesn't really have anything else. He also has a history of sarcoidosis. On his exam, he's fully neurologically intact. So this is the PET scan that he came with. Can you sort of tell me what you see here?
Yeah, so I see a sagittal and an axial PET CT. It seems to have a high increased metabolic activity in the thoracic spine, as well as the looks like the posterior lung, primarily on the left.
Yeah, exactly. So, you know, good. Like you talked about kind of what it involved. So what do you want to do? This guy comes to your clinic. What do you want to do?
You know, as was mentioned, get a thorough history and physical, as well as an accurate neurologic exam. There's already a PET CT, potentially follow up with an MRI with and without contrast of the T-spine.
Sure. He actually comes in, let's see, he comes in with the CT scan. This is the, thoracic spine. This is the affected level. So kind of what do you see here on the right?
So on the right is a axial CT of the thoracic spine, a bone window. I see some kind of erosion through the left pedicle extending into the body and lamina, likely lytic lesion, possible met.
Okay, good. Yeah, and you can tell it's sort of like you said, involves kind of spreads intrathoracically, next adjacent to the lung. This is the MRI that you were looking for. This is the contrasted scan. So kind of what do you see here in terms of where this tumor is and what it involves. So this is the sagittal and axial.
See, so it looks like a homogeneously contrast enhancing lesion. It's a little bit difficult, but doesn't look like it's originating from the dura. There's no like overt dural tail. I think it looks, likely extradural, extramedullary contrast enhancing lesion.
Okay, good. And what do you notice about kind of where it is here on this axial on the right?
It looks like it's possibly originating from the left thoracic nerve root. Again, it's modestly contrast enhancing. I would say, top of my differential would probably be neurofibroma.
Okay, good. Anything else that kind of involves the foramen, kind of in this area?
Of course, given his history of prior cancer, there's, must include metastasis on the differential. Other differential diagnoses would include possibly a schwannoma as well.
Yeah, good. So yeah, exactly. So meningioma, schwannoma, neurofibroma, any metastasis. And then also he has a history of sarcoidosis, so you can't, so there's a possibility this could be a sarcoid lesion as well. I'll turn over to Dr. Saad.
So Dr. Rosenberg is still working on this case, but for the sake of this presentation, we're going to assume it is neurofibroma. So what is neurofibroma? Is a tumor of the nerve itself, and the tumor cells have this wavy, elongated cytoplasm, which nucleus, which helps us a lot at the time of frozen section. And this is the permanent. The background is usually a little bit edematous, and there is no atypia, no pleomorphism. And neurofibromas are positive for S100. So for the time being, it is neurofibroma, and I'll let you guys know what happens with the molecular studies.
Hey, thanks, Dr. Sada. I got to tell you, this case has been going on for weeks and weeks. I talked to Dr. Rosenberg yesterday, and even after the molecular study, there's still no diagnosis. It's the most bizarre thing ever. I mean, he has a history of melanoma. At surgery, it definitely looked like it invaded the bone. It was very brownish. It abutted the chest cavity aorta. But I got to say that, even 4 weeks later and 3 biopsies, it's still not 100% clear what it is. It's definitely not a neurofibroma. Not a melanoma met. It's an unknown tumor. I've never seen that before.
Yet to be classified.
And I guess, Damien, if you're here, how would you treat this, and kind of like, what would the steps be to this surgery, just given that involves the foramen and you have that, sort of involvement of the bone ventral to the tumor?
Sure. So, obviously surgical resection recommended to figure out what the tumor is and try to remove it completely. Typically for these types of lesions, you have to do a transfascicular approach, from posteriorly to get access to the foramen and get ventrally as well. We'd probably have to sacrifice the nerve root on that side since it's thoracic. It's should be okay. And then instrument like 2 above, 2 below. Since you're taking out the pedicle on that side of the tumor, you probably just have to put 1 screw in at that level.
Good, awesome. So yeah, exactly. So as Dr. Levy mentioned, it was this like brown maroonish tumor in the epidural space, and so because it involves the T3 nerve root, and that's not really an essential nerve root for motor function, sensory function, you can actually tie it off to really get around, to be able to do that transpedicular decompression, really like remove that entire extent of tumor. You do vasectomies on the right side, the left side in this case. At T23, T34, you do transpedicular at T3 and partially of T4 as well, because I didn't include that CT scan, but it involved a little bit of T4 to get access to the lateral vertebral body and remove it. And then you also want to remove some of the involved rib head and, sorry, not intrathecal, it would be intrathoracic tumor, because it involved, it, again, spread into the chest cavity there and was adjacent to the lung. So just for kind of educational purposes, I'll just include this as a neurofibroma and just kind of talk about that. So neurofibromas typically arise from the dorsal sensory nerve roots, and again, they're also very slow growing, so you can see remodeling of adjacent bone, like you saw here. This can cause thinning of the pedicle and scalloping of the posterior vertebral body, like you see here. So they actually arise from the endoneurium and the connective tissue of the peripheral nerve sheath, and the actual histology shows kind of a mixed appearance in terms of the cellularity. So this is actually the most common peripheral nerve sheath tumor, equal in both male and female. Peak age of onset is relatively young, 20 to 40. About 5 to 10% of neurofibromas can turn malignant, and you can see this with more rapid growth on imaging as well. The most neurofibromas are sporadic, but as you all know, can occur in the setting of neurofibromatosis. And both of these are associated with deletion of the NF1 gene on chromosome 17. And as Dr. Saad mentioned, so this is kind of, if the classic neurofibroma seen on histology, you're going to have sort of these spindle cells that are kind of loose, pink myxoid collagen matrix in the background. Pretty low cellularity. You can have some mast cells within the tumor, not very many mitoses, and kind of hyperchromatic small nuclei. Okay, next case. David, are you on?
Yeah.
Okay, great. This next case. It's a 59-year-old lady, 1 month of progressive cognitive and speech decline, word finding difficulty and confusion. This is her exam. Again, I just highlighted the positive findings. She's not oriented. She has both expressive and receptive aphasia. She can repeat but not name anything, and she has a slight weakness in the left arm. So what would you do next?
Yeah, so in this case, I would run cranial imaging on this patient. It looks like she's having dominant hemispheric symptoms.
So this is the CT scan that they got when they came in. Yeah, and what do you see here?
Yeah, so you see mass lesions located via left temporal lobe, and has a pretty extensive amount of vasogenic edema surrounding it.
All right, good. Anything else you want?
Yeah, so I would want to get an MRI of the brain.
Sure. This is
and
what
as well.
Exactly. This is what the MRI shows. So non-contrast T1, contrast T1. You have diffusion on the right side.
Yeah. So enhancing lesions with solid system components, and like I mentioned, surrounding edema. So my principal concern here would be neoplasm, but can also consider other things like infection on the differential as well.
All right, good. Good. So I guess I guess what kind of tumors do you think are you thinking of when it comes to something like this?
Yeah, I mean, given the time course of her symptoms and like the imaging findings, I'd suspect something like a high-grade glioma in this case, like a GBM would be the top of my differential.
Awesome. And then Dr. Heroes kind of mentioned, in terms of looking at imaging alone, the differential between GBM, abscess, things like, tumor factive MS. Is there anything that you see that's different on the contrasted T1 when it comes to each of those tumors, or each of those, diagnoses?
Yeah, so the abscess would be more walled off. You wouldn't necessarily have like the heterogeneity that's associated with a tumor. And that's the case.
Yeah, exactly. So, Dr. Hirose mentioned on GBM, you have enhancement, and the borders are going to be thick, more irregular. Metastases, it's going to be more thin and regular. You can also, lymphoma, abscess, like you mentioned. Abscess would centrally have diffusion restriction. You can have tumor factor MS. And with tumor factor MS, that enhancement along the border is sometimes more incomplete. And toxo, you have usually sometimes it's smaller lesions and more multifocal. Dr. Saad.
Okay, thank you very much. Okay, so this is the tumor, and this is one of the most striking examples of significant atypia and pleomorphism. And actually, you can see some of the tumor cells. Here you can see them better. Some of the tumor cells have multiple nuclei, so they fall under the category of what we call giant cells. And the tumor is significantly mitotically active. You feel you want to do karyotype on this cell. So bizarre mitosis, necrosis, vascular proliferation. The tumor cells are diffusely positive for GFAP, confirming their astrocytic identity. So astrocytoma with mitosis and necrosis makes it a glioblastoma. This is P53 is diffusely positive, which tells you there is an underlying TP53 mutation. By immunostain, the tumor cells were negative for IDH, which means IDH wild type. ATRX was retained, which means ATRX wild type. So this is a glioblastoma, giant cell, and epithelioid features, a grade 4.
All right, there we go. Okay, good. Turkey, are you on?
Yeah.
Okay, good. So this is a GBM. How would you treat this, and what are the goals of the surgery?
Yeah, so treatment for GBM, given this location, I would do awake craniotomy. It's in the dominant hemisphere. Usually with GBM, you want to treat it both surgical and also with chemo radiation therapy.
Okay, good. And what are your goals of surgery in terms of the treatment of this?
So maximal safe resection with awake craniotomy.
Okay, good. And sort of, can you kind of walk through what your surgery would look like? How do you do an awake crane?
Yeah, so you would do. So you're going to basically, when you do the craniotomy, the patient's going to be sedated. He or she will not be intubated. And as soon as you make your craniotomy and you open your dura, then you wake the patient up, and then you try to localize where the speech area and the motor area is while the patient is awake and while you're resecting. But before you resect, you're going to do with an Oatman stimulator. You want to make sure where these eloquent areas are. Once you define them, then you can start your resection, and you can also stimulate while you're resecting to make sure you're not traversing any subcortical or white matter fibers.
Okay, good. All right. Yep. So this is what was done here. Given the proximity to the speech area and the symptoms of aphasia, the left frontotemporal crani opened the dura, awakened for cortical mapping. They found that the supra middle temporal gyrus didn't have any contribution to speech, so they did corticectomy here. They decompressed the cyst, and they kind of removed the tumor wall, which mostly came on block. And you can see there was like a little focus of tumor medially within that cyst that was also removed. So just kind of quickly going over GBM. GBM is the most common primary brain tumor. It's the most common glioma as well. Mean survival time typically 12 to 18 months. It's usually supratentorial. It can be either primary or secondary. So primary GBM is something that arises de novo instead of progression from a low-grade glioma. The vast majority of these are actually IDH wild type, and they account for the majority of GBMs, about 70%. Also, the other thing is primary GBM occurs in older people than secondary GBM. So secondary GBM, on the other hand, is due to progression from a low-grade glioma. 60 to 90% are IDH mutant, and these are actually more common in the frontal lobe. And so I think, Ahmad, you're the last person. So, right, so some of the big, tumor markers to look at GBM or IDH, the MGMT methylation, and EGFR. So do you know for IDH, if it's wild type versus mutant, how that relates to prognosis? Which one has a better prognosis, which one is worse?
Yeah, so with IDH mutant, you see a better prognosis. IDH wild type, you see a worse prognosis.
Yeah, exactly. How about MGMT promoter methylation?
MGMT, I believe if it's methylated, worse prognosis.
Yeah.
Oh,
Exactly.
sorry, it was a backwards.
So
yeah.
So MGMT unmethylated is worse. So why is that? Do you know why that is? And kind of, or I mean, the more important question is how do you treat something with MGMT promoter methylation?
Can you use like a demethylase promoter, like a,
yeah, usually
like
it's like alkylating
decitabine,
agents that
I
you
think,
use for one of the drugs in the alkylating agent category. And then how about EGFR? Which one is better prognosis?
EGFR amplification, I think it's worse.
Yeah, exactly. So not amplified means better, amplified means worse. So just kind of quickly wrapping up and going over the histology. So in GBM you have like a significant hypercellularity. You have numerous mitotic figures as well as kind of nuclear atypia from the rapid division. If you look at these microvascular, you have microvascular proliferation with a large amount of blood vessels, and you actually see this is here. It's called glomeruloid proliferation around the vasculature, and this it's because it looks kind of like a renal glomerulus, and so you see that. The other thing you see is, necrosis and palisading tumor cells around the necrotic foci. So you see here this kind of central area of necrosis, you see tumor cells around. And so, yeah, that's all 4 cases for today.
All right, thanks so much. So we'll talk a little bit about updates in vascular neurosurgery and really just go through some cases for the residents and fellows. So my funding disclosure, my training, I'm always interested from the residents and fellows to hear how they got here, to the positions that you guys are in every day. And I always think about my training, some of it was fairly painful, but it was also, some of the best times of our lives. College, I thought maybe looked a little bit like this, but maybe it was a little bit more like this. And I'll never forget my med school advisor when I came back as a junior. She said, back again like a bad coin. I already told you wouldn't get into medical school. So I diverted down a different path for a while. And I was a climber for a number of years. And I worked for search and rescue and in Yosemite. And then for the rest of, for 3 or 4 months a year, and then climbed around the world for the rest of the year. So an average day could look something like this, or climbing in Asia, something like this. And at that point, I thought you really can't get through a day without having an impact, but it really wasn't the impact that I wanted to have. I was having a lot of accidents, and over time I realized I wanted to be I'd much rather be the doctor than the patient all the time. So I went back to school in New York, residency, University of Virginia. At some point along the way, I had a kid, and then fellowships at Jefferson, back to UVA, Auckland, New Zealand. My time in Auckland and New Zealand had really a dramatic effect on me because they're so far ahead of us in the approval process for endovascular devices. So even then, which was over 10 years ago, we had many devices that were just getting to the United States now. And this is after that, my son looking around maybe for a little plot of land in New Zealand, and eventually we made our way to Miami. But really, one of the reasons I took the job here is the infrastructure for research, which I'll come back to at the end of the presentation. And this is my lab, or our lab, in the biomedical research building. So certainly my friends would tell you that I didn't become a complete tool until some point in my training. And I think the idea is that if you just have a hammer, everything looks like a nail, even if it's a rabbit. And sometimes when you put those two things together, you end up with a lot of nails in the head. And part of it also with all this training is you don't know who you're going to be surrounded by. I didn't know that I was going to be in Miami with such excellent partners, such great fellows and such great residents. And some of that is the environment that you walk into, and some of the things like the research team and your mentors are things that you walk into, but you also have to build. And the one thing about my training that certainly was grilled into my head or yelled at me on sort of a daily basis was we do it the same way every time. I don't think there was a single day that went by that I didn't hear that. And I think that that's important when you're first starting out and you're just learning how to do a procedure and you're perfecting it. But then over time, we've got to be able to do things better than we were doing them before. And so we're not doing them every time. I mean, we've got to figure out ways to innovate and treat our patients better down the road. When I think about vascular, I went into vascular in part because I really liked open vascular neurosurgery. I didn't really have much interest in endovascular, but going forward, endovascular really sparked a lot of my interest, in part because we haven't changed much in how we do open vascular neurosurgery, but endovascular devices and treatment modalities change on almost a daily or weekly basis. We have a new device. So I generally think, again, as Mr. T would say, rules are for fools, but they really can help guide us. And I do think we see some interesting things at University of Miami and Jackson and down here that maybe we don't see elsewhere. Like this gentleman that made a homemade rocket launcher and it hit him in the face. So I thought we'd go through just some case presentations. It's the start of the year for residents that may not see some of these things on such a regular basis. So first case, 68-year-old acute onset of aphasia, right facial droop, right side of weakness, 0 out of 5. CT shows no hemorrhage. CTA shows a hyperdense left MCA sign. CTA, you can see a clear cutoff of the left MCA. And we've changed how these patients come through the ER. They used to come in the ER and it would take hours before they could get up to neuroendovascular suite. Versus now, most of these patients were alerted by EMS. They actually skip the ER. They go straight to the CT scanner. The CT is done. If it shows no bleed, they get TPA in the CT scanner while the CTA is going, and then they come straight up to endovascular. So our average time from door to TPA is now about 12 minutes, which is mind-blowing, on the part of the neurologists and all the people that make that happen, the people in the scanner. Because when I was starting, it was usually about 3 to 6 hours. So here you can see a M2 cutoff. Another thing 10 years ago, we were not chasing smaller vessels like that. And this is just a quick video, sort of showing you that type of a case where we can go up with a guide catheter and then many myriad of different devices and take the clot out. I actually had to present this case on my oral boards. This was one of the first cases I did. I think this was in 2015 or 2016. And they gave me a hard time on the oral boards because I went radial to take this clot out, and that was something that really we were only doing previously for the right or left vertebral artery, but really never for like a thrombectomy like this. On top of that, at that time we were using this device a lot, the Solitaire, which was originally made for aneurysm coiling and then evolved into something that we remove clots from the brain. And this is, these were really remarkable big changes. We wouldn't have chased an M2, we wouldn't have gone through the radial artery. And over time, these things are changing very quickly. So you can see here revascularization. This is the patient on the table in the angio suite, now smiling, talking, moving one side. So flashing forward, we started using large bore aspiration catheters. This was a case also actually from 2016, which is still my fastest revascularization or our fastest revascularization. It was about 5 minutes and 30 seconds to take this clot out from the basal artery that previously a cardiologist actually, this happened in the cardiology suite, and the cardiologist tried to take the clot out, was unable to transfer the patient over here from the VA, and it was exactly 5 minutes and 30 seconds from groin to remove this. So over time, we keep getting better and better. This was about 2017. You can see here, we're starting to do much more complicated cases. This is a patient with a ICA stenosis of about 99% and an M1 clot. So you can see here, this was actually the last patient enrolled in the DAWN trial, where we moved the needle from doing thrombectomy from 6 hours all the way out to 24 hours. So what we did here, we used a lot of devices. We did an angioplasty, and then you can see here the carotid is then open, and then we went up and removed the clot from the middle cerebral artery. Here's the clot, post-revascularization. This is the last patient in the Dawn trial on the table, went from an NX stroke scale, I think 17 or 18 down to 0. And this was that publication from the Dawn trial. So still a lot of unanswered questions. We're still trying to raise money to do this trial, which is a comparison of a standard support catheter to balloon guides. These both have a lot of advantages and disadvantages, but generally speaking, our outcomes are better with balloon guides than with standard support catheters, but balloon guides weren't that trackable in 2015 or 16. So now we do have some better balloon guides, and we're still trying to raise the money to do this trial. Some other studies that have been approved that we're just about to get underway. One is looking at much larger catheters. So now we have these giant catheters that we can get all the way up into the middle cerebral artery, and it makes it easier to suck out clots. On top of that, we've really been using the same pump to remove these clots since about 2015, and we'll have some big updates there in terms of pumps that help us remove these clots more easily. So stroke, when we look at the pieces of the pie of stroke, intracerebral hemorrhage is a much smaller aspect than overall ischemic stroke. But there's still many different types of stroke, as you can see here. So next case, 68-year-old, acute onset of aphasia, right facial droop, right side of weakness, 0 to 5. This patient had symptoms for 3 days. We get an MRI that shows these embolic alterations. Here you can see severe stenosis in the internal carotid artery. It's a very short segment, and this is a fairly straightforward case. These patients get maximal medical therapy, and then this was the publication in Crest that you can see here with endarterectomy versus stenting. Endarterectomy did a much better job of preventing stroke, 2.3% versus 1.1%, and also death. But if you lump together troponin leak and MI, stenting did better. And overall, I'd much rather have a troponin leak than a disabling stroke. So I think we favor endarterectomy. But the reality is it's really based on patient and disease characteristics. So something like this, that's a long segment, stenosis in an unhealthy patient, potentially with a dissection, stenting is a better option. And so now we're moving on to CREST 2 to look at, mainly asymptomatic patients. We're still defining, based on patient and disease characteristics, what's the best treatment for extracranial carotid stenosis. Next case, this was a case that one of my co-residents was actually doing when I was in residency. And you can see here, they're doing an extended transsphenoidal to remove what they thought was petrous apex granuloma crystals. And this is probably one of the scariest things that you'll see. And residents always say, what's the first move when you hit the carotid? So step one is, go change your pants and underwear. And then once you've done that, you want to get the largest Foley catheter you can, stick that into the nose and expand it. And so that's why I always tell, the residents, whenever they're doing a transsphenoidal, you should always have the largest Foley catheter in the room. And that was something Dr. Jane taught me. So my record was 3 carotid blowouts on one Christmas day. And I think that was the day, I really thought about changing jobs. But even something like this is something that we've changed over time. So when I was in practice or training, we would sacrifice the carotid, or we would clip the carotid and do a bypass if the patient failed BTO. Flashing forward a number of years, we started doing pipelines, overlapping pipelines for some of these patients if they failed the BTO. And now we even have some newer devices. This is just in the last couple months. This was the case. You can see here, the parent vessel is 5.5 millimeters, which is really a problem. We don't have stents. The pipeline is not big enough to occlude this vessel. So we have this new balloon mounted, completely covered stent. And so it was made to cover coronary artery perforations. It's more trackable. It's thinner. It goes up to 5.6 millimeters. So we can get this all the way up to the ophthalmic segment. It does require an IRB, which we now have in place. You can see here the balloon going up, the stent is deployed, and you have immediate hemostasis. So unlike a pipeline, which is about 30% metal, this is 100% coverage and will immediately stop bleeding. And so we've now, I think, done about 5 cases, and we're writing that series up. Next case, this is a case in New Zealand, 25-year-old, difficulty swallowing, thought to have this progressive neck tumor. You can see here this giant tumor quote tumor here on the screen. And at this time, the fellow in New Zealand, a head and neck fellow, was doing this case, and actually the attending, unfortunately, was in Fiji, and they put the needle in and didn't get any tissue. And the fellow called the attending and said, well, just put the needle in further and make sure that you get tissue. And they never looked at the delayed post-contrast CT scan. So this upper row is a CT, CTA. And because this was a pseudoaneurysm with a small hole, the contrast is getting in slowly. And so they always did a delayed CT scan post-contrast at 5 to 10 minutes. And you can see here, there's a giant pseudoaneurysm. So I was operating in the next room. The fellow ran in and grabbed me, and literally there was blood painting the wall 15 feet away. So we got this patient down to endovascular after just putting, our hand over the hole. You can see here, this is a much larger covered stent, a Viaband, which is Gore-Tex lining, and that immediately stops the bleeding. Our ENT folks commonly do these big neck resections, and sometimes they'll even ask us to put these stents in beforehand because they can literally cut down onto the stent, and then they can remove the tumor off of the carotid artery. You can see here a visualization of that stent in this case, and over here you can see this massive resection cavity. Next case, 68-year-old right facial droop, right side of weakness, again, 0 out of 5. You can see here this very large intracerebral hemorrhage of the basal ganglia. CTA shows no vascular malformation. ICH is still something that we really haven't pushed the barometer on, and early mortality is tremendous, 35 to 50%. So we have been able to take some of these clots out in a minimally invasive fashion. Some of these trials are still ongoing. We can use mapping. You can see here, with just a little incision in the eyebrow and a tiny, 1 centimeter orbitozygomatic craniotomy, we can go down. And what you're going to see is us putting in the brain path here. So when we first started doing these cases, I would have been really worried about sticking a tube, or as Dr. Hiros loves to call it, a speculum, into the brain. And I'd be very worried about tearing the vein with these devices. But over time, we've realized if you open the sulcus, you can go straight down the sulcus. You can see here, take out the clot. That's actually looking down into the ventricle. There's the vein patent afterwards. Here's the post-op scan, versus the pre-op. Patient just has a couple stitches under the eyebrow. And we're still, unfortunately, enrolling in the ENRICH trial to look at this. And part of that is what we realize is patients don't want to be randomized. I mean, these randomized trials are very difficult to enroll in, and we'll talk more about that. That's certainly one of the things that's made some research really challenging. I mean, patients want you as the doctor to decide, should they have surgery or not. And it's only for a certain subset of patients there's actually equipoise. So for Aruba, when we were enrolling in Aruba, that was just for a very specific narrow set of AVMs, mostly grade 3, grade 4, where we had equipoise about what was the best treatment. So we'll come back to that, but that's been some real challenges in terms of enrolling patients in randomized vascular clinical trials. Next patient, 93-year-old, presents with right side of weakness, 4 to 5. They're on aspirin for coronary disease. They're on anticoagulation for heart valve. They have all these medical comorbidities. You can see here this pretty large symptomatic subdural hemorrhage. And for this patient, we just did middle meningeal embolization. So we go up through the middle meningeal artery, we inject embolic material, and we can glue off the middle meningeal artery and all the membranes. And you can see here, here's the pre-op scan, and on the bottom, the 3-month scan, that subdural hemorrhage is completely resolved, and the patient's deficits all resolved as well, and that's without surgery. Another similar patient, 90-year-old, PE, DVT on anticoagulation, COPD, hypertension, hyperlipidemia, diabetes. You can see her large symptomatic subdural hemorrhage. Top row, before embolization, bottom row, just embolization, completely resolved, patient completely functionally independent at 3 months. So there's still a lot of unanswered questions about MMA embolization. We have a lot of new embolic agents, and we just got approval. We're going to start enrolling for a randomized clinical trial for subdural hemorrhage as well. Next case, 35-year-old presents with weakness, headaches. CT scan shows this hemorrhage here. I think we all know in a 35-year-old, that's a bizarre location. Angiogram shows this dural arteriovenous fistula, fed from the ethmoidal branches and from distal branches off the ophthalmic. So for dural arteriovenous fistulas, it's all about finding the exact fistula's point where it exits the dura. And as long as you know where that point is, these cases are easy. This is a patient who's treated at another hospital. And what you're seeing here is the onyx cast. And what you can tell is they never reach the fistula's point and there's no onyx in the veins. And this is the run. You can see here, the veins are all filling. So this is the onyx and this is the run. And you can see all these giant dilated cortical veins. And that's because none of this onyx material gets to the fistula's point. And if that happens, you're not going to cure this fistula. It's going to grow new vessels in, even if you take out the feeding arteries, and the fistula is going to come back, usually worse than it was before. So this is now with a septor balloon. This is something we didn't have until about the mid 2000s. That allows us to inject more onyx or more glue in a controlled fashion and fully cast the fistula's point. You can see onyx now filling all of these veins. So that patient was completely cured. And again, with these patients, it's all about knowing where the fistula's point is. When you first look at an MRA on these patients, it can be fairly overwhelming. What you can see here, this patient was actually an Army general. He presented with exercise intolerance, blurry vision, weakness. You can see here it's got a Chiari-1 malformation, and you can see all these dilated vessels. So as long as you know where the fistula's point is, which is right next to the superior sagittal sinus here, we can go up and coil this off, and this patient made a complete recovery. So with fistulas, the way that I think about it is just, are they low risk, medium risk, high risk? Low risk, drain into a large vein that can easily tolerate that blood flow. Grade 2, drain into a vein, but in the opposite direction away from the heart. And grade 3, drain only into the cortical veins. So it makes sense that those patients, if you have a high blood flow draining into just cortical veins, they're at higher risk for hemorrhage, seizures, neurodeficits, and those are the patients we pretty much are always treating. We really don't have the time to talk about all the options for fistula, but microsurgery, embolization, and radiosurgery are all potential options with various pluses and minuses. So for someone like this, with an anterior cranial fossa, dural arteriovenous fistula, the easiest approach is surgery, far and away. And I don't know why, even recently, there was another publication comparing this, showing the obliterations and endovascularly with only about 60% with a much higher complication rate. We've also published on doing these cases through a less invasive fashion. This one we did with just a tiny incision in the eyebrow with a endoscope. But we can't always do, these microsurgical cases. This is the same case, but this patient is 80. They've got all these medical problems. You can see here, this ethmoidal fistula is draining into the superior sagittal sinus. And so for someone with a lot of comorbidities like this, we can go transvenously with a microcatheter. We can see here all the way down here, down to the fistula's point, put some glue in and cure this fistula. On top of that, in the same patient with a lot of comorbidities, if it's only draining into cortical vein, we can go out the ophthalmic artery with these improved microcatheters that we have. The key is going past the central retinal artery. We can inject glue and we can occlude something like this. But that being said, this has a lot higher risk than of blindness than an open microsurgical approach. So I would really only consider this in a patient that's high risk for microsurgery. But you can see here, we were able to fix this. And you can see at the end of the case, a patent choroidal artery. 30-year-old presents with progressive headaches, exercise intolerance. Next case, 93-year-old presents with eye pain, decreased visual acuity, progressive ophthalmoplegia, proptosis, high output cardiac failure. You can see the eye exam here. This was another case I think I did in 2015 or 16 that I had to present on my oral boards. This is a high-risk case, patient with a direct CC fistula. You can see our imaging has improved gratefully. And there's no good approach to this. I tried for a long time to go transarterial, then I tried to go transvenous through all the occluded branches. You can see here, this is a tiny cavernous ruptured aneurysm that bled into the cavernous sinus. So ultimately, I placed a needle directly under the the globe down through the orbital fissure, sticking the vein directly, and then we can coil this off. And this is the patient afterwards. So this patient made a complete recovery, but still a controversial case to do a direct stick in a 93-year-old. And I had 2 extended conversations with the family before, proceeding with the case, something like this that's so risky. The other thing to think about when we're doing these endovascular cases, especially for fissures, is where are those coils going? And this was another case, an epidural AVM done by another neurointerventionalist. They put this large coil mass in here. This is an epidural AVM, so it's outside the dura. But once they put this large coil mass in, it compressed the spinal cord, and we ended up, starting this case at about 2 in the morning. And you can see here, this is the nerve root after a 2-level thoracic approach, removing the pedicle from a lateral approach, and then removing all of those coils, obliterating the AVM, and putting in screws to fuse this patient. So you really got to think about when you're going to put this amount of coils in, where those coils are going and how they're going to put a mass effect either on the spine or the brain. 20-year-old presents with significant headaches. They've got a visual field deficit, some left-sided weakness. You can see this bleed here. You can see this very small AVM. So this is really a Spetzler-Martin grade 2. It's a superficial, it's eloquent for the visual alterations, superficial drainage, small size. So AVMs, we know the incidence about 1 in 100,000. We often talk about the risk of bleeding is about 2 to 4%. We'll come back to that. The options are always observation, microsurgery, radiosurgery, embolization. For someone like this can be a very straightforward removal of an AVM. And this is not necessarily someone we would have put in the Aruba trial. Again, the Aruba trial, there were a lot of editorials about why we couldn't finish the Aruba trial. And ultimately it was stopped early. You can see here, although we had something like 35 active sites, each site was enrolling about 1 patient a year. So that was really challenging. And again, it wasn't because we were enrolling all AVMs. It was because we were enrolling AVMs that we thought that there was equipoise about what the best treatment was. So mostly grade 3 and grade 4 AVMs, there were either low risk for bleeding or high risk for intervention or both. And so this was a patient that was enrolled in Aruba that was counted in the surgical arm because you can see here, very high risk AVM, not something that any of us would want to really treat. It extends into the motor strip. And this patient was unruptured, randomized to observation. And at the point that the surgery at the Aruba trial ended, which was prematurely closed, this patient only had 3 years of follow-up. That's when the Aruba trial was halted. At year 5, this patient had a hemorrhage and required a life-saving surgery. And so in the Aruba trial, this patient was counted as a success in the medical arm, even though eventually they went on to cross over to surgery. And this is what makes all this really complicated. But with 3 years of follow-up in most patients, you can see here, the intervention group had a much lower, the intervention group had a much higher morbidity and problems from treatment. So a lot of limitations. We could spend hours talking about this, but selection bias, treatment bias, proficiency bias, outcome bias, follow-up bias are all potential issues. And again, with AVMs, this is a great paper by Staff Perspective, which showed actually that the bleeding rate for AVMs varies from almost 1% per year to 34% per year, depending on these characteristics: age, hemorrhagic presentation, deep drainage, and deep location. So it's not just that all AVMs have the same risk of bleeding. And you can see that in these graphs here. So again, something like this AVM does not have a 2 to 4% risk of bleeding. You can see here there's 7 aneurysms associated with this AVM that are adjacent or proximal to the AVM. And this is a fairly straightforward surgery. We can go here, we embolize some of these aneurysms and then remove the AVM. You can see here there's coils and onyx in the vessel. These are those aneurysms. Another patient, this is a patient with no quality of life with almost daily, if not multiple seizures a day, despite 3 anti-epileptic medications. You know, again, this is a 6-centimeter AVM, so a fairly high risk for surgery, but left frontal, we can go into a left frontal lobectomy. This patient ultimately was off all seizure medications. You know, so when we talk about treatments, it's complicated, but again, for something like this is fairly straightforward surgery. And we know from publications from Dr. Spetzler, this is Dr. Hero's follow-up publication. This was the publication that we did when we were at Jefferson. You know, surgery for low-grade AVMs is fairly easy and should have very low morbidity and mortality, close to 1%. So if it was me and I had a superficial AVM personally in a non-eloquent location, I would want that removed. You know, the Aruba trial, only 66 patients received a single treatment. And of those, 46% received embolization, 49 received radiosurgery, and only 7% of patients in the trial received surgery alone. So Aruba was really a trial of natural history versus embolization and radiosurgery. And we know from numerous publications that we can stratify these patients better than that. You know, for someone like this, with this AVM in the motor strip, surgery is not the best option. You know, this is a patient we know from a number of publications that if they need to be treated and they have a high risk of bleeding, radiosurgery is a pretty good option. What about outcome bias? You know, real briefly, this is a 12-year-old presented with significant headaches, temporal left-sided vision loss. The vision alterations resolved primarily ophthalmology with no visual field deficit, otherwise neurologically intact. This patient's got 7 aneurysms and this 7-centimeter AVM. You know, and I would argue that the lifetime risk of bleeding is very high. This patient was having almost weekly trips to the emergency department because every time she had a severe migraine, she was worried that, you know, her parents was worried that it was bleeding. So they would take her to the emergency room, then she would get a CT scan. She did go to another hospital. At one point, they put a tiny drop of embolic material in this that did absolutely nothing. But with over 15 trips to the emergency room, you know, this is reasonable to consider taking this out. So we embolized the deep feeders and we took this out. You know, post-operatively, she has, as expected, you know, this is an occipital region, worsening of her homonymous hemianopsia. So according to the Aruba trial, this was a treatment failure, meaning a bad outcome because she had a new neurological deficit that was worse after surgery. You know, but I would call this a real win. She sent me this message on Father's Day. You know, this is her painting in the hospital. Ultimately, actually, her field cut completely resolved. And so again, in the Aruba trial with a short follow-up, she would have considered a failure. With long-term follow-up, her field cut completely resolved. She has gone on to be the Taft representative for the AVM Foundation. You can see here, this was at the Jackson Gala. So some limitations, and you know, we really need to think about this when we're talking about AVM. So again, clinicians were left to determine how these results affect contemporary AVM management. The question remains not whether AVM should be treated, but which treatment is optimal. Again, Aruba trial has not answered the question, but supports further studies and discussion based on risk management. And this was a great publication by Evan Luther and the rest of the team in JNIS. And they recently featured a podcast on this because they felt this publication was so important. And basically, following Aruba, what we saw is the treatment of AVMs went down, and the bleeding, the national bleeding actually went up. And we saw the same thing after the publication of ISHUA, the International Study of Unruptured Intracranial Aneurysms. So once that publication came out, primary care doctors were referring a lot less patients. And again, the natural history, the bleeding rate nationally for unruptured aneurysms went up as the treatment went down. Next case, 20-year-old presents with headaches and weakness, has this intracerebral hemorrhage. MRA looks consistent with Moyamoya disease. You can see here fallout of the intracranial artery with that puff of smoke appearance. You know, and background Moyamoya phenomenon, it's really a well-defined phenotype in Eastern populations, more common in Asians. It's about a prevalence about 3.6 percent with that bleeding rate there in about 100,000 persons respectively. and the interesting thing is in Asians, it has a well-defined phenotype where children that have inadequate collaterals usually spent with ischemic symptoms. Adults, they are lucky enough to make it to adults. They develop those collaterals, but they're fragile and they usually present with hemorrhage. And again, that's in the Asian phenomenon. So really our only treatment currently for this is still extracranial, intracranial bypass. A number of studies have shown this effective even in hemorrhagic patients. You can see here this bypass here. And this bypass, we did a double barrel and it's filling all the way down to almost you can see here the MCA bifurcation. And this patient has done very well. So, but still a lot of things are still being looked into. So what's the optimal treatment for this? How can we improve neurocognitive dysfunction in these patients? What are really the long-term outcomes? And then on top of that, this is another paper that we published that the phenomenon of Moye-Moye disease is much more heterogeneous in the United States. And actually, kids and adults are more commonly present with ischemic phenomenon, whereas in Asia, the adults more commonly present with hemorrhage. So still a lot of things to look at in Moye-Moye disease. Next case, 23-year-old, this is actually a medical student, complained of severe headache while studying, worst head of life, collapses. Took this patient 3 days, unfortunately, to get here, to be flown here. When they got here, they were grade 5, ARDS, MRI showed ischemic changes. They've got this subarachnoid hemorrhage, this aneurysm. Briefly, here's just a video of that showing the subarachnoid space, these vessels. I think most of the residents, fellows, familiar with this. You can see here, Circle Willis, aneurysm, creating shear stress. And I'll just skip this. So unruptured aneurysms, 1 to 9% of and I'll come back to that case at the end so we can talk about it more. But unruptured aneurysms, 1 to 9% of the population, highest in some of these patients. Smoking increases aneurysms, risk of rupture, mainly size and location. And this is something that's changed over time as well. This is from the unruptured intracranial aneurysm study, knowing that the risk of rupture changes dramatically with size and also location. But that doesn't mean that tiny aneurysms don't bleed. This is a ruptured ACOM blister aneurysm less than 1 millimeter. So the interesting thing about this is we know, again, in the Ishua study, we were enrolling patients that were low risk of bleeding, high risk of treatment, or both. So a 90-year-old with a calcified 5 millimeter ophthalmic aneurysm was a great patient to put in Ishua, and we know that they were probably not going to bleed. That differs greatly from a 20-year-old with 3 family members with aneurysms with a 2 centimeter middle cerebral artery. I mean, that patient we would have never put in the Ishua study. In the UCAS study, which was the Japanese unruptured intracranial aneurysm study, again, they put in patients that were low risk of bleeding, high risk of treatment, or both. And the really important thing here is very impressive. They put almost 6,000 patients in this study, 6,700 patients in the study. But ultimately, 3,000 patients fell out of the trial and received treatment because either they had aneurysm growth or patients decided down the road that they wanted the aneurysm treated. So again, these results in the New England Journal of Medicine are based on the 3,000 remaining patients. So you're talking about an incredible selection bias. So these are patients where we, again, low risk of bleeding, high risk of treatment, or both, enrolled in a study, and then half of the patients were removed in the next 5 years because they had aneurysm progression or they wanted treatment. In this study, again, they helped stratify risk of bleeding based on location and also Murphy's TIT. But the problem is they needed to have 3,000 patients to even start looking at aneurysm locations. This is one of the best natural history treatment studies by Juvela. And this was from Finland. These were patients that had an unruptured aneurysm and a second untreated unruptured aneurysm. We now have over 30-year follow-up on this. He publishes on this cohort every couple of years with updated follow-up, and it's amazing. So he's followed most of these patients now for up to 30 years, And what he showed was the bleeding risk was 1% per year. These patients had a 33% bleeding risk cumulatively over the follow-up. That's amazing. And of those, the average size of these aneurysms was about, I think, 4.5 millimeters. So tiny. So we know that these small aneurysms still do bleed. It's not that they have no risk of bleeding. It's just that there's a low risk. And our treatment has to beat out, for some of these cases, a 1.1% risk of bleeding per year. So if I had a treatment that I could carry out with a 1% risk, me personally, I would take the treatment because I have a 1% risk per year over the next 30 years. Me personally, I have a roughly 45-year life expectancy based on my age and my medical history. And over that time, if I had an aneurysm, there is a high chance of bleeding. So anyways, we can stratify these patients. What about ruptured aneurysms? We know they present with subarachnoid hemorrhage, but they're not all the same. Some of them can present with intracerebral hemorrhage, subdural hemorrhage, and even primary intraventricular hemorrhage. Additionally, some can present with mass effect. This is an aneurysm, and this is sort of my wall of giant herniating aneurysms. So we know that there's a big difference between these aneurysms. We need to have a better understanding of this. So, from our small aneurysms all the way up to our giant aneurysms. And they can present with mass effect, as we talked about, things like this, mass effect with third nerve palsy. And all of these things need to impact how we treat patients. So when, again, primarily when I was training, we were talking about clipping or coiling, and we were always arguing which is best. I think that argument is very antiquated. It's based on patient and disease characteristics that define the optimal approach. This patient, there's no reasonable endovascular option. Even today, unfortunately, I would argue, we still don't have a good endovascular option. There's an M2 branch that comes out of the wall of this. So this patient got a radial bypass and clipping. And, if my head looked like this after surgery, I'd be disappointed. This patient actually went on to make an amazing recovery and their weakness nearly completely resolved. But a high-risk case. When I was doing my training, Cassell, every aneurysm craniotomy got what we call the flap of Kraft. So giant craniotomy. Even a small MCA, he did these giant incisions and craniotomies. Moving forward, someone like this with 3 aneurysms, we can tailor our craniotomy. So someone like this, you routinely done. This is my craniotomy for that. You can see here the craniotomy is about 2 inches. We can go down. We can clip all 3 aneurysms through a tiny incision. Here's a craniotomy. Patient goes home with a Band-Aid. This was the father of one of the nurses here. Additionally, this was a model, a patient that had a previous aneurysm coiled, and she didn't want to keep coming back for coiling and stents, and she didn't want to take aspirin Plavix. She was very worried about the incision. So we did a little eyebrow incision. You can see here, this is an orbitozygomatic craniotomy through a 1-inch craniotomy. You can see here we did some cranioplasty material to smooth over the defect. Afterwards, we can go down. You can see here, clip this aneurysm, coils in place, post-op angiogram, and all this has minimal cosmetic results. 37-year-old presents with significant headaches, cranial nerve 3 palsy, return CR with significant headaches, and progression of that third nerve palsy. You can see here PCOM. This is pre-clipping, eye completely closed. Post-clipping, her eye is already starting to improve. And that's because we can clip this and then actually cut off the aneurysm so that's not causing pressure on the nerve. Still, these outcomes are better with open surgery than endovascular. She went on to make a complete recovery because we cut this aneurysm and then there's no pressure on the nerve. And as long as they come in earlier enough, these patients pretty much always recover. That being said, I'd much rather get poked with a needle than have an incision and a craniotomy. So, something like this, we can go up endovascularly, either through the leg. Now, a lot of times we do these procedures through the wrist and treat these things endovascular. I think you're all familiar with that. So something like this, ruptured giant ophthalmic aneurysm in a poor grade patient, endovascular treatment is for sure the best option. Other things, we now have larger coils to be able to do these procedures more faster. We do have some better filling coils potentially, and we've written a lot of prospective studies. This is from the SMART study, which is concluded We just completed the WAVE study, which is a prospective study of about 1,000 patients looking at outcomes of these patients, looking at different coil types. We have improved microcatheters, which allow us to treat some of these wide-based aneurysms potentially where we don't want to use a balloon, and we published on that. Or we can get away with doing a dual microcatheter technique sometimes for wide-based aneurysms, so they don't need a stent and they don't need aspirin and Plavix. But balloons have also gotten better, and we're able to coil through the balloons. We're able to place stent through the balloons. You know, again, when I was training, we would have never coiled a ruptured middle cerebral artery aneurysm. You know, now in a grade 5 patient, I would regularly consider a patient with a lot of comorbidities putting up a balloon and coiling a middle cerebral artery aneurysm, because we know that it's less invasive, to give the patient a chance to recover. And if they do, we can always bring them back and consider a stent or even clipping. Stent-assisted coiling, you know, again, we can place a stent to cover the base. You know, this is a picture of what that looks like. Sorry. And, you know, this is a case, this is one of the first cases I did here as an attending, you know, and I remember talking to Dr. Hiros and Dr. Marcos and the rest of my partners about this case, because this was a 78-year-old grade 4 ruptured vertebral artery aneurysm. You can see here the pica is coming out of the base. We did a reconstruction, which shows this is at the level of the IAC. So for surgery, which is how, you know, this patient would have been treated in my training, we would have done a pre-sigmoid approach. It's a massive surgery, you know, probably would have taken almost all day, very invasive. In a 78-year-old grade 4 with a swollen brain, I could tell you there's almost no chance that patient's going to have a good outcome. So this is a patient that we treated with stent-assisted coiling. After once we put the first coil in, we loaded the patient on tirofiban and then later aspirin Plavix. Now we've transitioned to aspirin Brilinta. So we can do these cases and we can do them better and better. And this patient is now completely functionally independent. So she was someone that the residents, you know, I remember we were having a discussion, 78-year-old, grade 4, didn't really improve with the EVD. We still treated them. She looked like death up until about day 7. She started to improve. She sends me a yearly Christmas card, letting me know that she's done well. She's now, I think, 83 and still drives. So with better stents and better balloons, we're able to treat these aneurysms better. We'll skip through this. You know, we've written up comparing stent-assisted coiling, balloon-assisted coiling, looking at long-term outcomes of stents. But again, it's not necessarily which is better. It's based on patient and disease characteristics, which is better. This is our publication at Jefferson looking at why stent coiling. And the interesting thing here is now with better stents, I haven't why coiled, I don't think, maybe one case in the last 2 years or year. And that's primarily because Atlas is so much better that we're able to coil these aneurysms with much, much better outcomes. And usually we can just use one stent. Flow diversion, another type of stent. You know, we can all see these cases, these untreatable cases. This is before and after flow diversion, before and after flow diversion, before and after flow diversion. And so when I was in training, we were just starting to use flow diverting stents, and it was only for giant aneurysms with a high risk of bleeding where we didn't have an alternative. You know, flash forward many years later, we've started publication extensively on different areas that we can look at flow diverting stents. So this case, this is a giant partially thrombosed aneurysm that leaked. And so this is someone, and you can see here, they also have these this dysmorphic vessel with 6 other aneurysms on the carotid. So for this patient, the aneurysm leaked. I coiled the partially thrombosed large part, and then at 2 weeks, loaded them on aspirin Plavix. You can hear a tiny flow diverting stent, covers all 6 aneurysms. You can see here on the follow-up, this aneurysm is completely gone. The vessel has completely reconstructed. And you know, that's someone that I would consider surgery because of the mass effect. But this patient was older with medical comorbidities, including heart problems. I think this is a pretty amazing outcome. She's now at about 6 years and still functionally independent. So for some of these giant aneurysms, coiling with flow diversion is a better approach. And we published a lot now looking, again, it's not is pipeline better than coils. It's based on disease and patient characteristics, what is best. And these were some of our most cited publications because what we found is over time, we had a better understanding of the device. So we can now, in prospective studies, treat simple aneurysms with about a risk of about 1%. So that's a major difference from PUFs for these giant aneurysms where the risk of treatment was more towards 10 or 15%. So for simple aneurysms, you know, we're going back to that Juvella study, maybe we should consider be treating these smaller aneurysms, and we need to revisit better trials and research, because for someone with a 1% yearly risk of bleeding that's 50 years old, personally, I would want my aneurysm treated if it can be done with a flow diverting stent with a 1% risk. So those are all the things we got to think about carefully when we're treating these patients. But again, it also is based on location. So a 7 millimeter unruptured middle cerebral artery aneurysm should not be treated with a flow diverting stent. So again, it's patient and disease characteristics. Other things, you know, we'll skip this, but sometimes we need to think about combined therapies. So this was a ruptured dissecting pica aneurysm, and this one we did a bypass and endovascular sacrifice because the brain was swollen. Other things, you know, we really can just blast through quickly is looking at new devices for wide-based aneurysms. We now have things like the Pulse Rider. We've done some research on this. This is the ANSWER trial. The Citadel study is just about to start, which is a much larger coil that allows better treatment of wide-based aneurysms. This is the Contour, which is another study that we're looking at starting to treat wide-based aneurysms. And some of these endovascular devices have no doubt made our treatments easier. So this was a patient that was previously clipped. This would be a very difficult case to go back and clip again, giving all that scar tissue. This is an easy endovascular case. So this is one area that pipeline has bailed out, you know, myself or open vascular neurosurgeons. Another case, patient with that underwent stent coiling and coiling 7 times with pressive edema and seizures. This was treated with a flow diverting stent. And again, another time where endovascular bails out endovascular approaches. But again, it's not without some complications. We need to be careful because new devices can create new complications. This was a flow diverting stent that was done by another physician that didn't deploy, and we had to go in with surgery and actually remove the pipeline. Delayed or distal intracerebral hemorrhages, you know, was a common phenomenon with pipelines early on because of material in those early guide catheters. So since we have better guide catheters, I can't think of a distal hemorrhage with a flow diverting stent in over 3 years. You know, again, other complicated cases where we put a flow diverting stent in, and this one we actually had to remove. This is another patient treated in an outside hospital where they dissected the vessel. The patient had a stroke, was throwing emboli, and the aneurysm's unsecured. We went in and did a bypass and trapped the aneurysm. So, you know, we still don't have the answer for all cases, you know, and we still need to have open microsurgery. You know, there's still not a good option for all these cases. This patient coiled 7 times in another hospital, presents with their second hemorrhage. They did a bilateral femoral angiogram. You can see here both femoral arteries are occluded, and they transfer the patient. This is the radial artery. You can see here massive blowout with a fetal PCOM. There's no endovascular option for this patient. So we went in, removed all these coils, did a clip reconstruction. Here you can see the carotid artery floating in the breeze. And, you know, this is really the only option for these patients. Coming back to our medical student, a 23-year-old, you know, again, she's grade 5. She's got ischemic changes on MRI, no improvement after putting an EVD. The family still wanted everything done. The best option for this sort of fusiform pericallosal aneurysm was clipping. On day 7, she went into vasospasm. We treated that. We treated her spasm on day 7, 8, 10. On day 12, she was doing basically nothing other than maybe questionably triggering the vent. I told the family I thought we should withdraw care. They refused. Day 14, 16, she was still doing almost nothing. Family refused to withdraw care. ultimately, and this is the treatment of spasm, ultimately over weeks, she was in the ICU, I think, for over a month. And then she went to rehab for 3 months. And this was when I ran into her in rehab. I just was blown away. I didn't even recognize her. Because when you see these people in the ICU, they look like corpses. And it's very easy to withdraw care. And when I was in New Zealand, these grade 4 and grade 5s, they just removed the endotracheal tube in the ER. There was not even a question of treatment. So this is this patient at rehab. This is this patient on follow-up. So she's returned. And again, grade 5, ischemic changes on MRI, did not improve with EVD, got clipping. This is her now. This was at her graduation. She plays golf. She came back here. She finished her master's degree and she just published her first paper. This is on recruitment problems for aneurysms. So I think this is really, a mind-blowing thing where we often consider withdrawing care too early on these patients. And another thing that's changed over time. So my Monday clinic, often I think of it being like this. These are the cases now I often see in clinic. Patient that was clipped, end stent coiled, repeated coiling, filling aneurysm despite flow diversion. These are the cases that the fellows are excited about. But my mom, she warned me about free candy. These are the types of cases that are very challenging. And we've got to be able to do these cases. And this is where research, I think, has a big role. I'm almost done. So in the research laboratory, we're looking at molecular alterations, how this impacts aneurysm growth and progression. Currently, our knowledge of aneurysms is inadequate. We need to have a better understanding of the basic biology to improve patient selection and non-invasive therapies. That can lead to medical therapies, imaging, treatment options. Medical therapies, it could satisfy an unmet clinical need. It could be better than existing therapy, rapidly available, cost-effective. So better than some of our endovascular surgical options. We're looking at how this alters cells, and then we move forward at the DNA level. We're also looking at novel imaging modalities, less invasive imaging, molecular imaging, antibody-mediated imaging. And we have a lot of models in the lab. These are models to test for embolic stroke, models for AVM, and the main one that we use is models for aneurysms. We're looking at stents and developing surface modifications, potentially delivering drug reservoirs, antibody-mediated stents, and cellular carriers. The pipeline flex with shield surface modification was developed by Medtronic, but we did a lot of the research to test this. And what we found was that this shield coating or surface modification decreased thromboembolic phenomenon, increased obliteration. I think I placed about 180 stents in a rabbit model. This was the first patient that we had to get compassionate use to use shield in a dissecting basilar aneurysm that had ruptured. Patient went on to make a complete recovery. And then we did publish, our basic science data looking at shield technology. We've gone on to do other compassionate cases like this. We didn't previously have a 6 millimeter stent. This was a giant growing basilar aneurysm. And so in the lab, we have new surface technology that we can potentially treat these aneurysms better. This clinical trial sponsored by Medtronic is about to start, which looks at shield technology for ruptured aneurysms that are wide-based, that are not amenable to endovascular surgical treatment. So I think all blister aneurysms should be enrolled in a study like this. And I'm going to skip some of this, but we've got, good results looking at a lot of different linings for these stents now. This is endothelial coverage at 3 post-procedure at 1 week and at 6 months. And so we're working on funding, but thankfully we're supported by the NIH, Department of Health, the Glasser Foundation, these other foundations, companies, consultants, donors. So I have to thank all of them. And we're working on these future clinical trials. So again, this 100-year-old with this aneurysm is high risk of bleeding, but also high risk for intervention. So potentially we should be looking at new imaging, new medical therapies, or considering new endovascular surgical options. And so in conclusion, multimodality assessment is necessary for all complex vascular lesions, and thankfully we've got a great team here. Technologies continue to provide minimally invasive treatment options, but research needs to keep up with these improvements to carefully assess novel complications and outcomes, and further trials are necessary to better define the optimal treatment. It's not clip versus coil, it's what is the best option based on patient and disease characteristics. That was a mouthful. I know I blasted through that. Thank you so much. I always got to thank my son. He's now starting to come with me to a lot of these cases, especially on the weekend. Thanks very much. Questions?
Can I make a comment? Can you hear me?
Yes, sir.
I just want to say spectacular talk. You covered the entire field of vascular surgery in 1 hour, and just makes me think how far we have come along. If anybody thinks that neurosurgery is not moving, it is incredible the changes since the time I was doing this to now, Robert. And I hope the residents notice that almost all of the statements you made here, you are supported with literature and articles that you have written, and most of them as either first author or senior author. So that's just spectacular. I have to say that we're so fortunate to have you here. Thank you very much. This was just great.
Yeah, thanks so much. And as you know, you're a major reason I came here, a huge inspiration at looking at how we started doing all these things. And I feel incredibly lucky to be surrounded by such awesome faculty, fellows, residents, staff that help us out on a daily basis. So thanks so much.